Question 28, which of the following is the most likely cause of his kidney injury? Renal, right away. 63-year-old man is admitted for evaluation of acute kidney injury. Recently completed a 10-day course of antibiotics for pneumonia. New onset fatigue, decreased appetite, but nice flank pain, hematuria, dysuria, blah, blah, blah. History includes hypertension, eczema, hyperlipidemia, vital signs. Physical exam shows a faint maculopapular rash on his trunk. That's really important. And creatinine is 3.2. His baseline is 1.1. So that confirms our kidney injury. BUN is also elevated. UA reveals hematuria, pyuria, sterile pyuria, really important, and white blood cell casts. Most likely cause, why don't we start from the bottom? Let me mix it up a little bit today, get a little crazy. That could be a heart attack, suddenly dropping blood pressure, shock, any type of shock, acute hemorrhage, which would be hypovolemic shock. Basically, like I said, something that reduces blood flow to the kidney, at least temporarily. We really don't have any history of that. He had pneumonia, so it's possible he had sepsis, but they didn't tell us that. They usually tell you that sort of thing because it's very pertinent positive. We can also do our BUN to creatinine ratio to figure it out. So BUN to creatinine is going to be 45 divided by 3.2. We got to pull the calculator out for this, and this is exactly why we didn't go to engineering school. 14. So we got 14. If your BUN to creatinine ratio is over 20, and I've seen different sources on this, but I believe 20 is what's in the onking, then it's pre-renal. If it's less than 20, it's either intra or post-renal. Can we make sense of that? Maybe. If you had a pre-renal injury, meaning there's just not much blood flow getting to the kidney, you're going to retain both BUN and creatinine. But if you have an intra or post-renal azotemia, that means there's probably going to be something wrong with the nephron itself. And so it won't be able to absorb as much BUN as it could normally. Your BUN and creatinine drops, but creatinine is always just secreted. It's never reabsorbed. BUN is secreted and a little bit's reabsorbed. So if there's something wrong with the absorption process, your BUN is going to drop more than it would with a pre-renal azotemia where there's nothing wrong with the reabsorption process. So post or intrarenal, you would see a much lower BUN relative to the increased creatinine. So in a pre-renal azotemia, there's nothing wrong with the nephron, so it can still absorb BUN. So your BUN will be increasing. Creatinine is never reabsorbed. Creatinine is still going to increase because we are not getting enough blood to the kidney to get rid of our creatinine, but whatever blood does get there is still going to be filtered properly by the nephron, and so you're going to get relatively more BUN than you would creatinine because, again, we can still reabsorb BUN. There's nothing wrong with the nephron. On the other hand, if we had an intrarenal process, if we had something wrong with the nephron, that changes how we handle sodium, water, and BUN. So creatinine is going to increase because there's something wrong with the kidney. Maybe we're not able to filter as well anymore. If we're not able to filter as well, then BUN is going to increase also, but we're not going to be able to reabsorb extra BUN like we could with the pre-renal because, again, there's something wrong with the nephron. It's just not working anymore. So these two might be equivalent. Maybe even creatinine rises a little more, but this is why the ratio stays, it hovers around the normal 15 range. Same thing with post-renal. Early on, it looks like a pre-renal azotemia because there's nothing actually wrong with the nephron early on in the disease process. But later on, that's when things start to back up in the nephron gets damaged, and then it starts to look like an intrarenal process. So it really depends on the stage for post-renal. So based off our BUN and creatinine ratio, we know this is either an intrarenal or post-renal process. What in this patient's medical history would predispose them to either? We're thinking post-renal, that's something beyond the kidneys, maybe a ureter stricture or a BPH. Again, we don't have any signs of that, no symptoms, no medical history of anything like that. But they do give us some history. Recently, he did a 10-day course of antibiotics. That is something. So I'm going to cross off pre-renal azotemia because it doesn't match our actual BUN to creatinine ratio. Urinary obstruction also doesn't make sense, right? The post-renal thing, we just don't have any signs or symptoms or medical history of that. Post-infectious glomerulonephritis, so PSGN. PSGN would be an intrarenal process, so our BUN to creatinine ratio would work. It's usually after a group A strep infection, so think strep throat, and 63-year-olds usually aren't getting strep throat. Think teenagers for strep throat. So this one I'm gonna cross off for this as well. Strep throat also doesn't present with pneumonia. Next up, we're left with acute interstitial nephritis versus acute tubular necrosis. These two are commonly mixed up all the time, but they're actually pretty easy. So we've got ATN and AIN. ATN is due to a vascular insult or a nephrotoxin. And so think shock or antibiotics, drugs, IV contrast, anything could be a nephrotoxin. I see a lot of questions about ATN and AIN where they talk about recent antibiotic use or recent IV contrast use. Honestly, I wouldn't rule out one or the other just based off of the medication that they were given. There are some that are more prevalent for one or the other, but again, I wouldn't rule something out just because it doesn't exactly fit your criteria. So vascular insult, again, that could be like shock. We don't have any history of that, but we do have the antibiotics. So that could be a nephrotoxin. And it generally just presents with an AKI, and usually that's all they tell you. This guy has a faint maculopapular rash though. So again, I mean, it's some UA findings, sterile pyorrhea, hematuria, white blood cell cast. I wouldn't rule out anything just because it doesn't exactly fit your diagnostic criteria. So let's think about AIN and see which one makes more sense. So this one is typically due to just nephrotoxins, or in this sense, A in AIN can be acute or allergic interstitial nephritis. I like to think of it as allergic because it helps me remember atopy. So AIN presents with AKI, which we have, fever, rash, eosinophilia. We've got a rash. We are not told about his vitals. We're not told about eosinophils, but look in the UA, we've got some hematuria, some sterile pyorrhea. So we know it's not a UTI. It's just white blood cells and some white blood cell casts. Now, if we're thinking about casts, that could be AIN. And actually, I should actually add that here. Sometimes if they're nice, they'll give you the muddy brown casts, or they could call them pigmented casts, or even just tell you about tubular epithelial cells in the UA findings. We really don't have any of those descriptions in our UA here. It's white blood cells and white blood cell casts. So those white blood cells very well could be eosinophils. And we've got the rash. We just don't know about the fever. Now, remember, when I say AIN could be allergy, allergies are associated with atopy. It's so important to remember atopy comes up all the time. So atopy is a triad of three things that tend to come together: atopic dermatitis, which is eczema, allergies, and asthma. So if you're ever considering AIN or one of these three diagnoses, always check to see if there's a history of atopy. So let's see. Does he have anything? History includes hypertension, eczema. There it is right there. So there's his history of atopy. It really is starting to make sense now. Plus we have the maculopapular rash. So just more things pointing towards AIN. And so the correct answer is B.